Today I'll be presenting my paper on Panhypopituitarism and central diabetes insipidus secondary to diffuse large B-cell lymphoma. This presentation was put together by myself, Kyle Schwarz, and Eric Tharmathurai. We're at the Christ Hospital in Cincinnati, Ohio. So this was an interesting case, and that I'll get into, let's give some background information. So diffuse large B-cell lymphoma is actually the most common type of non-Hodgkin's lymphoma in approximately 25% of cases. And usually the typical patient that we see this is a middle-aged or elderly individual with a median age around the 6th decade of life. Patients are typically having rapidly enlarging masses in the neck, groin, or abdomen area, and associated B symptoms of a fever, weight loss, and drenching night sweats. And for this case, it's pretty interesting because these lesions rarely go to central nervous system involvement, and rarely do they ever affect the hypothalamus, causing central diabetes insipidus and panhypopituitarism, as I'm about to present. So to set some backgrounds for this patient, for the case presentation, we have a 27-year-old male with a past medical history of stage 4 testicular diffuse large B-cell lymphoma. He had actually undergone treatment in the past. He had undergone R-CHOP, rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. He's had intrathecal methotrexate, and he also had a right orchectomy. And then he presented to our hospital at this point with emesis, agitation, and altered mental status. Vital signs at admission were 90.4 Fahrenheit. He had bradycardia into the 40s and 50s, and he was also hypotensive. We had some pertinent labs, which I'll discuss in a minute. And off of the electrolyte panels, we noticed that he had a sodium of 163. So in the ED, we got a CT head. It showed a 2 centimeter subcellular mass, and follow-up MRI was suggested, which we ended up getting, and I'll go into that in a moment. So for his hospital course, we started workup for his hypernatremia. He was started on D5W. He had slight improvement in his serum sodium, really going from like 163 to 150. Urine osms at that time were around 183 to 285. At this point, we were worried that there was a component of central diabetes insipidus given the mass, and he was started on desmopressin with excellent response. He was also found to have a low TSH, and a T3, T4 were also low, raising suspicion for central hypothyroidism. Thyroid replacement was started with levothyroxine, and we also started beginning workup for cortisol levels being low. He had a baseline around 6, kind of made for hard interpretation, but he was started on hydrocortisone at this time. Primary hypogonadism was also expected in this patient since he had his previous orchiectomy, and he was actually already on hormone replacement therapy on admission. We had completed bone marrow biopsies and LP, and both of those were negative at this time. So kind of the interesting findings for the case was the MRI. As you can see here on the pictures below, and the read that we got was the amorphous areas of the nodular enhancement centered about the third ventricle along the bilateral anterior thalami and the hypothalamus, measuring 1.7 to 1.6 centimeters. Kind of using all this combined, we had to kind of come up with a reason as why we have this patient who's having these symptoms. And using that past history, we were able to kind of put 2 and 2 together, seeing that he's got this MRI with his lesion, and then it was concluded that it was likely a secondary lymphoma due to the stage 4 testicular non-Hodgkin's lymphoma. After improvement from the treatments that we gave him, he was actually able to discharge from the hospital and was doing very well. Unfortunately, he did come back at least twice to our hospital due to non-compliance, but each time being placed back on his regimen, he did very well. Very interesting case because, these are relatively common, but the incidence of a CNS relapse and diffuse large B-cell lymphoma is around 2 to 6%. And it is even more unusual to see the secondary CNS lymphoma with diabetes insipidus and hypopituitarism due to the hypothalamic involvement. One of the kind of learning points for this case is just the the challenges with diffuse large B-cell lymphoma and needed to always be thinking about surveillance on these patients since there is a risk of relapse. So just kind of moving forward, just further investigating these patients and always be having that in the back of our minds. A very interesting case and good outcome since our patient is doing well, and we're happy to present it, and thank you for your time.